Okay, so you want to buy a hospital. White coats, ambulances out front, a business that never runs out of customers because people never stop getting sick. But here's the strange part. A hospital is one of the only businesses on Earth that's legally required to treat anyone who walks through its emergency room doors, whether they can pay or not, and yet it's also one of the most consistently profitable industries in the American economy. And it's also one of the most fragile. Hospitals are closing at a rate that would terrify almost any other industry. By the end of this video, you'll know exactly how a private hospital actually makes its money, why the emergency room isn't the moneymaker most people assume it is, how one private equity deal turned 31 hospitals into a national scandal, and why some of the most profitable healthcare companies in America are quietly closing the exact hospitals that made them rich. Hospitals come in 3 sizes, and the capital required is unlike almost any other business you could start. A small private medical practice, the kind with 1 or 2 physicians and no inpatient beds, costs $70,000 to $500,000 to open. That covers your lease, basic equipment, an electronic health record system, and enough working capital to survive your first year while patients and referrals build up. A small community hospital is an entirely different scale. Even a bare-bones critical access hospital with 25 beds or fewer typically requires $30 to $50 million once you account for construction, medical equipment, and compliance. And a full-scale general hospital, the kind with a real emergency department, surgical suites, and imaging capacity, can run anywhere from $60 million to over $200 million, with construction costs alone averaging around $500,000 to $1.5 million per bed. A single MRI machine costs $1 to $4 million on its own. This is before you've treated a single patient. 2 more costs nobody warns you about. The first is licensing and accreditation. Federal certifications and compliance reviews can take months to clear and cost tens to hundreds of thousands of dollars just to process. And if you want to accept Medicare patients, which most hospitals need to survive, that adds an entirely separate certification process on top. The second cost is staffing before you're profitable. Personnel typically eats 45 to 60% of a hospital's total operating costs, and you're paying full salaries for physicians, nurses, and administrators for months before enough patient volume walks through the door to cover it. Now we get to the question that actually matters. The honest answer surprises most people. It's almost never the emergency room, and it's definitely not an even split across every patient. A hospital's real product is a system called payer mix, the specific blend of who's paying for each patient's care and at what rate. Here's the mechanic in its simplest form. Private insurance companies typically pay hospitals the most for the exact same procedure. Medicare pays significantly less for that identical service, and Medicaid pays less still, often less than what the care actually costs to deliver. So hospitals survive through cross-subsidization. Profit from privately insured patients quietly covers the losses generated by Medicare, Medicaid, and uninsured patients. When that balance tips the wrong way, a hospital starts bleeding cash no matter how many patients walk through the door. Now here's where it gets specific. Surgical suites are where the real money is made. The operating room accounts for up to 65% of a typical hospital's entire profit margin, even though it's a small fraction of total patient visits. A single elective outpatient procedure generates an average contribution margin of over $4,000 per case. Advanced imaging like MRI and CT scans is nearly as valuable. Together, surgery and imaging represent only about 20% of total hospital services, but they generate close to 80% of total operating profit. Meanwhile, the emergency room, the department everyone assumes is the moneymaker, actually runs on razor-thin margins around 7 to 8%, and that number only holds up if enough privately insured patients show up. Take away the private payers, and emergency departments swing deeply negative. Medicare patients in the ER generate roughly a 15% loss, and Medicaid patients generate closer to a 36% loss, on average, per visit. Now, the architecture, not of the building, but of where a hospital chooses to grow. Every profitable hospital system is quietly engineered around expanding its highest margin service lines. That means aggressively building out orthopedic surgery, cardiovascular surgery, oncology, and advanced imaging, because those are the departments with both high commercial insurance reimbursement and high procedure volume. It means keeping operating rooms running at 85% utilization or higher, because every idle hour in a surgical suite can cost thousands of dollars in lost opportunity. And it means, less visibly, being cautious about how much emergency and low reimbursement care a facility takes on relative to its profitable service lines, which is exactly why hospital closures disproportionately hit rural and low-income areas first. Those facilities have the worst payer mix and the least surgical volume to offset it. And then there's the industry's real retention system, not a loyalty program, but referral networks. Specialists build ongoing relationships with primary care physicians, insurance networks, and other hospitals specifically to keep a steady stream of high-value surgical and diagnostic patients flowing in. A hospital's growth strategy often looks less like advertising to the public and more like recruiting the referring physicians who control where patients get sent for surgery or imaging. Which brings us to the hospital equivalent of whales. It's not 1 in 1,000 patients. It's specific service lines: cardiovascular surgery, neurosurgery, orthopedic surgery, and oncology consistently rank as the highest revenue-generating specialties in American hospitals, each contributing millions of dollars in annual net revenue per physician in these specialties. A single cardiovascular surgery program can generate more net revenue for a hospital than an entire primary care department combined. This is why hospital systems compete fiercely to recruit specific surgeons, not just to add capacity, but because one high-volume surgeon can single-handedly move a hospital's bottom line. So here's the whole revenue model in one sentence. High-margin surgical and imaging services, cross-subsidized by favorable private insurance, offsetting government and uncompensated care that would otherwise sink the balance sheet. So with billions in revenue flowing through the industry, why do so many hospital owners still go broke? The short answer is the same cross-subsidy math working in reverse. When a hospital's payer mix tilts too heavily toward Medicare, Medicaid, and uninsured patients, which happens most often in rural and low-income areas, there simply isn't enough commercial insurance profit left to cover the gap. Add labor costs eating 45 to 60% of the operating budget, expensive equipment that depreciates fast, and mandatory emergency care that can't be turned away, regardless of ability to pay, and the margin for error becomes razor-thin. For reference, even HCA Healthcare, the largest for-profit hospital chain in America, with over $70 billion in annual revenue across 190 hospitals, operates on a net profit margin of only around 8%. That thin margin is where most hospital owners lose, and it has 2 repeat patterns. Mistake 1, leveraged financial engineering instead of patient care. The most infamous recent case is Steward Healthcare. A private equity firm bought the system in 2010, expanded it to over 30 hospitals across the country, then sold off the underlying hospital real estate in a sale-leaseback deal that forced Steward to pay itself rent it couldn't actually afford. Executives and investors extracted over $1 billion in dividends, while hospitals ran out of basic medical equipment. By 2024, Steward filed for what became one of the largest hospital bankruptcies in history, with over $9 billion in total liabilities, and several of its hospitals permanently closed, cutting off emergency care access for entire communities. Mistake 2, ignoring payer mix until it's too late. Rural and safety net hospitals across the country have closed at an accelerating rate, specifically because their patient population skews too heavily toward Medicaid, Medicare, and uninsured care, without enough commercially insured high-margin surgical volume to offset it. Unlike a nightclub or a restaurant, a struggling hospital can't simply close its doors overnight. Regulators, courts, and entire regions depend on it staying open, which means the financial reckoning often arrives later and hits harder. Step back for a second because the economics here are genuinely strange. A hospital is legally obligated to treat people who cannot pay, and yet the industry as a whole remains consistently profitable. Some of the largest for-profit hospital chains post billions in annual profit. The system only works because of an invisible balancing act. Enough privately insured, high-margin surgical patients have to walk through the door to subsidize everyone else. The moment that balance breaks, because of a bad location, a shifting local economy, or a private equity firm extracting cash faster than the hospital can generate it, the entire structure can collapse almost overnight. And unlike most businesses, the fallout doesn't stay contained to a balance sheet. It shows up as ambulances driving 20 minutes further, and mothers giving birth without the equipment they need. Time to pull it together and answer the actual question. How much money do you make if you do this right? 2 scenarios, real numbers. Scenario 1. A single, well-run community hospital or specialty surgical center with disciplined focus on high-margin service lines like orthopedics and outpatient surgery and a healthy commercial payer mix. Operating margins in the range of 8 to 12% are realistic for a well-run mid-size facility, translating into several $1 million in annual profit for a hospital generating $50 to $100 million in revenue. Payback on the initial capital typically takes many years, given the scale of investment required, but the cash flow, once established, is remarkably stable compared to most industries because people never stop needing medical care. Scenario 2. A large multi-hospital system at HCA's scale, $70 billion in annual revenue, an operating margin over 12%, and net income exceeding $5 billion a year, built entirely on disciplined focus on surgical volume, imaging capacity, and favorable payer mix across nearly 200 hospitals. At that scale, a hospital chain stops being a single facility and becomes a portfolio, where underperforming hospitals with bad payer mix get sold off, and capital gets redirected toward the surgical centers and imaging suites, generating the highest returns. So if you do decide to buy a hospital, just remember the actual rule of this business. You're not really running an emergency room. You're running a portfolio of surgical suites, and the emergency room is simply the legally mandated cost of keeping the lights on.